friends, Namaste. I am Dr. Sandarbh Patel, DM Interventional Cardiologist, practicing in Ahmedabad. My clinic is at Aradhya Heart Care, Paldi, Ahmedabad. Today, I am going to discuss with you all about certain things about hypertension, particularly some updates, latest updates in hypertension. If we start with some epidemiologic data, then as per WHO, nearly 63% of total death in India are due to non-communicable disease and 27% are attributed to cardiovascular disease, which affects almost 50% patient in 40 to 70 years age group. And large chunk of Indian population is in 40 to 70 years age group. Raised blood pressure is the most important risk factor for cardiovascular disease. So that way we can tell that in India, uncontrolled hypertension, raised blood pressure is the major cause contributing to the death of the people. Now, if we see the prevalence of hypertension, over the last 30 years, it has increased so much. Initially, it used to be somewhere between 20 to 30% in females and males. Males, of course, higher. Latest data shows that the incidence in males is almost 38% and females is also 32%. And these people, out of 100, 38 or 32 people male and female may have hypertension. Among them, only 50% of the male and 40% of the female are aware about their blood pressure situation. Others are not even aware that they have hypertension. And those who are aware, among that, 62% of the male and 53% of the female did not get treatment. And of those getting treatment, only 20% of the males and 15% of female had adequate control of blood pressure. So with lot of medical advances and lot of clinics, physicians, super specialists and all, still India has high number of hypertension, which is not diagnosed, not treated, and if treated, then not adequately treated, which is very worrisome. So what are the few basics to high grade guideline points? International Society of Hypertension has released ISA 2020 Global Hypertension Practice Guidelines. In that, standard of care from how to measure the blood pressure, office hypertension, office blood pressure monitoring, home blood pressure monitoring, ambulatory blood pressure monitoring, all guidelines are there. In ACCAHA scientific statement, if stage 1 hypertension is there and low atherosclerotic cardiovascular risk, score less than 10% is there, then in up to 140 and 90 milligram of mercury blood pressure, one may just give non-pharmacological therapy and lifestyle modification and exercise and all, and try to review at 3 to 6 months. Lowering the systolic blood pressure target should also be kept in mind. Like previously, it used to be the target of 110 and 70. But then there is that U-shaped curve where beyond certain limit, if lowering of blood pressure is there, then it can be harmful. So systolic blood pressure target of 130 and diastolic blood pressure target of 80. And in certain age, say beyond 60 years, 130 to 150, and beyond 70 years, accepting even 150 by 90 or less of the blood pressure can be very helpful, and that leads to decreased composite CVDs, because very low blood pressure is also harmful and increases the cardiovascular mortality. So by age and by risk factor criteria, you should target the blood pressure control and not extremely stringent blood pressure control. Out of office measurement like ambulatory blood pressure or home blood pressure monitoring is also very important. In that 24-hour as well as nighttime BP measurements are recorded, and if 20 by 10 mmHg increase at night leads to increase in mortality by 23% and cardiovascular event by 36%. So out of office nighttime blood pressure monitoring is very important. It helps in targeting the early morning surge, and the early morning surge, mind you, dear doctor friends, is responsible for many events like stroke or heart failure or acute MI that occurs in the early morning, especially as the winter is approaching now. And one important thing about adherence to the treatment, 2018 European and many other guidelines have given focus on non-adherence to the treatment. To reduce that non-adherence, combination therapy to start with initially, like ACE inhibitor, ARB along with CCB or diuretic would be a good thing, which leads to good control as well as single pill. So adherence and compliance issue is less. Now, if we see certain other studies, like I was mentioning about nighttime blood pressure control and all, one study, Hygia, was there, which tested nighttime antihypertensive treatment, and this is known as Hygia chronotherapy trial. So, from switching to morning dose of antihypertensive drug, when the antihypertensive drug, at least single or multiple drugs, were given at night time, and then ambulatory blood pressure monitoring were done. So there was good control, night and early morning surge was there. And with that good nighttime control of blood pressure, relative risk reduction in CV event was there in the range of 15 to 20%. Another important thing in all or any of the latest update in hypertension is that some drug may be preferable to other drug. Previously, say few years back in the guidelines, beta blocker drugs were also first choice of drug or first line treatment option, but now it is not a first line treatment option. ACE inhibitor or ARB, calcium channel blocker like amlodipine and other congeners, and diuretic like chlorcelidone or hydrochlorothiazide would be first choice depending on the indication. But beta blocker also will become a first choice antihypertensive treatment in certain class of patients, like if they are post myocardial infarction hypertension patient or particular arrhythmia is there. And of course, important update that is to be kept in mind throughout is that whatever previous combination patient is on and blood pressure control is good, then just to meet the newer guideline, switching over of particular class of agent is not required. If a patient is on age-old therapy of atenolol amlodipine combination, is doesn't have any other compelling indication, and there are good blood pressure control, then that treatment can be continued. So this was my effort to create awareness among doctor colleagues and others about few updates in the hypertension guidelines in 2020-2021. With this, I'm signing off. Thanks from Dr. Sandarbh Patel, cardiologist, Ahmedabad. Thank you.